Should we be reducing the dose of our induction agent when performing RSI in the emergency department in shocky patients? We know when we perform RSI, we run the risk of dropping the patient's blood pressure, resulting in peri-intubation hypotension and even cardiac arrest. This is why we stress resuscitation prior to intubation so much. The better we resuscitate that patient, the less likely that we endure these hemodynamic derangements. But does changing the dose of our induction medication make a difference? We know that no matter what induction medication we give shocky patients, we're going to drop their blood pressure because we're removing the patient's intrinsic catecholamines. But depending on what agent we use, we can exacerbate that effect. Propofol is a good example. The more propofol we give, the more hypotension we get because there is a dose-related hemodynamic effect. The same doesn't hold true for ketamine and etomidate. They don't have a dose-related hemodynamic effect. So any dose of ketamine or etomidate can drop the patient's blood pressure, but a higher dose isn't more likely to drop the blood pressure than a standard dose. And remember that when we reduce the dose of the induction medication, we run the risk of awareness during paralysis. So if you're using propofol, reduce your induction dose in those shocky patients to avoid peri-intubation hypotension. If you're using ketamine or etomidate, it probably doesn't make much of a difference.